we are very happy to greet you here in the very first session of today of this beautiful event, Precision Medicine Networking Forum. And I think this session, the session is called Precision Medicine in Oncology and Cardiology. And if you look at the program, it is quite eclectic. And I think it's a very beautiful representation of the topics of all these two events happening during these 2 days, because this is going to show that the precision medicine is not only for the oncology, but also in other fields of the medicine. Also, we'll be seeing that there are not only genomic analysis, but some other analysis as well, approaches. Also, we will be able to see and learn the experience of our neighbors. I'm very happy to announce my co-chair, Professor Gustavs Latkovskis.
Hello, and I'm not sure if you introduce yourself. You're Inese Cakstina-Dzerve, so I'll introduce you. So welcome everyone to this session. We will keep our introduction very short, but I think it's very important to see that it's not only oncology, but also cardiology, and of course many other medicine fields where precision medicine plays more and more important role. So without further ado, I will give you...
Oh yeah, and one organizational thing is like we're all gonna have our speakers to talk, and we were going to have the question and answer session after all 4 speakers were going to finish talking. So if you have some questions, please write them down, and then we can do the discussion at the end of this session. So with no further ado, I would like to ask on the stage Kristina Ojamaa. She's an oncologist from the Estonia. So we are starting with the learning from experiences of our neighbors. Thank you.
Okay. Good morning to everyone. So I'm an oncologist, and currently I work actually in North Estonia Medical Center, but I worked also in Tartu University Hospital, and there I'm still connected to there with Estonian nationwide precision cancer medicine trial ESTOPRET, so somehow I'm connected to Tartu University Hospital as well. So I try to give a very fast and quick overview what we're doing in this cancer area and molecular oncology in Estonia, and what we have achieved so far. First, I'm going to talk about a little bit broader about the TROOP trials, and I thank previous speaker, keynote speaker, who actually very well introduced this topic. TROOP trial, I think all of you have already somehow heard about it. It's a drug rediscovery protocol trial, and it's a trial where we use drugs that are that have authorization to use for patients in certain indication, but in this trial we do not use them in this certain indication, but due to this molecular profile and the mutation that would interact with the drug. It's a targeted therapy trial. So there are a lot of trials around Europe, around the world, like TROOP-like trials, and we call them TROOP-like clinical trials, like TLCTs. So this is quite a big challenge for the whole country and for healthcare system as well, as we learn a little bit later. So what is the idea really, and what kind of unmet needs it will actually answer? So we know that the promise of prostate cancer medicine is quite clear, and patients would benefit from that. And what we know is that we have a standard of care, but at the end of it, what happens next? Patients are fit. We should treat them further, but how? So it's kind of a tale of the molecular oncology, really, to treat patients with cancer that have exhausted standard treatment. So it's a big challenge to everyone if you think that it can be how benefit is for the country. I mean, the financial issues there behind. But it makes it very challenging, and we know that it will help the treatment. So Estonia is a small country, as well as Latvia, I think, as well as Lithuania, for example. Even Denmark call themselves a small country. So it's very hard to find the possibilities to lead such a trial in a small country. So first trial that is very well published was Shiva trial that was conducted in France, and it was a very negative trial. It was published in the Lancet of Oncology in 2015, and it was very much criticized. I think that the knowledge that we have today, it's okay that it was criticized, but the lesson learned, and we went forward for that, and many new trials actually started with more knowledge and more better results. So what is the troop trial design, and what is the aim? The aim is to show that the drugs, targeted drugs, which are given concerning the tumor molecular profile, is very beneficial. So, and at the end, it should be beneficial for the financial background for the country as well. So the designs of the trial, the troop trials, are quite much the same, and we use Simon two-stage model. The idea of this model is to get the most precise and quicker results with the smallest number of subjects. So the first stage of the trial, we tried to include 8 patients, and if at least one patient has a clinical benefit, so we can go on with the second stage, and we add 16 more patients, and if at least 5 patients have clinical benefit, we can say that this drug is beneficial for this type of patients or tumors. So we go on for the first stage then, and it's an expansion cohort, and on the 16-week we measure if there's a benefit of the drug again, and if there's on the week 16 there's a benefit, so the country's healthcare system should take over the financing of the treatment of the patient. So this kind of, as I said, it's a huge challenge for the country and also all the collaborators. So really patients would benefit for this precision cancer medicine. So here is a map of Europe, as you can see, and Estonia, Tartu University Hospital, also belongs to the consortium called Primrose, which is led by Kjetil Tasken from Oslo Cancer Center, and it's a EU-funded project. And the aim of the project is to facilitate precision cancer medicine to European patients, and to help establish these troop-like trials in every country. And this consortium really has helped us as well. And we have really good connections with all consortium members, and the best connection we have with Finland. And to establish such a project, we share quite much the protocol as well. So in this Primrose project, there are 19 countries all around Europe and 28 institutions. So the oldest trial, actually, who also has published a lot of data already, is the Netherlands and the DRUP trial itself. And we know that IMPRESS Norway is also publishing a lot of data already, and it's very well organized, and we try to be as good as they are there. So what is also the aim of this trial is to somehow organize precision cancer medicine in the country. This trial is the, how to say, almost top of specialty, so all this cancer molecular profiling and molecular oncology should work for this and organize for this, that the patients benefit for this treatment. So this Primrose is really, really helping us a lot. So Primrose not the only huge European project. The previous one was precision medicine for all European citizens that was held by, or led by Hans Gelderblom from the Netherlands, from Leiden University, and this project actually started to harmonize molecular profiling in Europe among the consortium members, and I'm very glad to say that in Tartu University Hospital our molecular oncology is very comparable to Northern Europe ones. So I'm very happy about it. So we are also in a high level, which is very, very big step for the trial itself. So what is the ESTOPRET itself? It's Estonia Precision Oncology trial, and we try to improve access to targeted anti-cancer therapies. So, and it is sponsored by Tartu University Hospital. And of course, the objective is to evaluate the anti-tumoral activity and also toxicity. And the drugs that they use have to have the authorization from European agencies or from the United States or from the Asian agencies. And the patients who we include this trial, they have to have performed molecular profiling, and they have to have the tumors that harbor a certain DNA, RNA, or protein mutation that can be targeted with a drug. So this is a prospective, open-label, non-randomized basket or umbrella trial. It depends what kind of partners we have. I mean, the drugs and patients all together. And we can have only one cohort, or we can have multiple cohorts for that. So patients should have exhausted their oncological treatment, or we still have cancers that have no standard treatment. They are also welcome to this trial. They have to be fit. We call it performance status by ECOG. It's 0 or 1, and they have to have panel testing for the tumor. So in Estonia, it's the study design is as follows. The right part is also this Simon-Dusted study design almost, and the left part is this Estonian part, more or less. So if the treating oncologist sees that the patient have exhausted the oncological treatment, and the doctor thinks that maybe in this type of tumor there might be some kind of mutation that can be targeted by new drugs. The doctors actually orders the molecular profiling of the tumor, and if there's a certain type of tumor, that we have the cohort in the trial, so the patient signs the informed consent, and this molecular profiling result, and the patient cancer history goes to molecular tumor board. If it's suitable mutation for the cohort and for the drug, so it goes to ESTOPRET multidisciplinary team meeting and molecular tumor board, and it will go as follows: the design is. So in Estonia, molecular profiling of tumor tissue is reimbursed by healthcare system, and we use the Illumina TrueSight Oncology 500 panel. If the patient wants or knows something about NGS panels and they want something else, so we have commercially available other panels as well. And what is very good is that all primary endometrial and ovarian cancer undergo NGS testing in Tartu University Hospital, so it's reimbursed, and that's why if we take our data together, 50% of NGS testing is performed for gynecological cancer, 30% for endometrial cancer, and 20% for ovarian cancer. And it all comes from the international guidelines, actually. So we have a molecular tumor board, which is a very good one, I think, even though it is not as deep and as many people do not attend it as, for example, in Oslo University Hospital, but we started already in 2021, and it is organized all by Tartu University Hospital. We have a lot of members there as well. We probably need a clinical pharmacologist as well, but there's oncologists, there's a clinical geneticist, clinical laboratory geneticist. We have already a molecular immunologist, laboratory specialists to work with the specimens and the technology and the diagnostics. We have a bioorganic chemist, the youngest professor in Estonia, and the pathologist, and of course the secretary, most important one. And we have a lot of cooperation among institutions in Estonia and even abroad. All Estonian cancer centers are involved, Tartu University is involved, and also Helsinki University is involved. So where the science meets clinical actions is ESMO scale of clinical actionability of molecular targets. So in this area, we do not use this tier 1 at all because it's a standard of care. We are discussing mainly this tier 3, 4, 5, and this X there, so it's important. So we start in Estonia, I hope in January already, with the first cohort. It's for rare gynecological tumors that harbor PA3K mutation, and we are very happy that we almost concluded our collaborations with Novartis, that we have alpelisib in the line to come, and really it's a big step forward that we can start all those discussions with patients, with these authorities, with our health fund, and reimbursement issues for targeted cancer treatment. So I thank you all the teams here, and I hope that someday with Latvians, with Lithuanians, we have the same cohorts and share the same data, and all our cancer patients will benefit from molecular oncology. Thank you.
Thank you very much, Dr. Thank you very much, Dr. Ojamaa, for your very nice talk. So we'll proceed with the next talker, who is a geneticist from Riga East Clinical University Hospital, Dr. Aigars Dzalbs, who will be talking about implementation of new highly effective molecular pathology diagnostic methods and services for the development of precision medicine and oncology. And I understand there will be some scope also on economics of the health as well. Thank you.
Thank you very much for your kind introduction. Thank you very much, organizers, for this nice conference. And I have a honor to present the data from our project. It's a very large team in our Riga East Clinical University Hospital, which consists from from geneticists, from clinical geneticists, oncologists, and so on. And it was very nice to hear that in Estonia there are many more reimbursement for genetic testing and for therapies, not like in Latvia. For example, in Latvia, for endometrial cancer, we have no such tumor profiling reimbursed by government. And before 2 years, we are starting to looking how to develop in future. And there was announcement of European Union and National Health Service project for introducing the new methods and evaluating their effectiveness in clinical practice. It was one evening we are sitting together with surgeons, with oncologists, with pathologists, geneticists, and we have to decide what to do and what is the best, how to introduce these methods in clinical practice in Latvia. I would like to stress that Riga East Clinical University Hospital is the largest hospital in Latvia, which provides 80% treatment for patients with oncology. And we put together, and it was very nice to hear today that we following this model which proposed by professor in this morning from tissue, from patients, from sample tumor to germline mutations and consultations, and further for surveillance and treatment. Our study is approved by Latvian Central Medical Ethics Committee. We are focusing on these colorectal and endometrial cancers, and for germline mutations we are looking for Lynch syndrome, and also this is because the Lynch syndrome is not only the germline or hereditary disorder, but there are in tissues we are looking for some markers for other diagnoses, for other patients with cancer, and we can diagnose the patients which have not the cancer, but which may respond to the therapy. And now we looking what to do, how to introduce these methods, what to choose, what to testing, and how to testing, and we compare the PCR and NGS methods, and provides genetic consultations to the patients, and develop clinical algorithms for these patients. And of course, it is possibility to identify these presymptomatic family members which have maybe this hereditary disorder. When we starting this project, before 2 years, it was only 2 patients in Latvian registries with Lynch syndrome. Lynch syndrome is not a rare disease. It has this orphan code, but in reality, it's not a rare disorder. It's 1 to 300 patients, individuals, not the patients, and it makes a large amount of people who are underdiagnosed with this disorder. And if we are looking for statistics, then in Latvia, almost 1,500 new cases for these cancers are diagnosed annually, and probably 50 patients may be attributed to this syndrome. And there may be some changes in therapy for these patients who have Lynch syndrome because they are not respond so well to the chemotherapy, but probably respond well to the immunotherapy. And also there is need some changes in surgery, in procedures. We are looking, there are 4 genes which are coding these proteins which are involved in mismatch repair system. And if we are looking on this lifetime risk for the cancer, we can see it's very high for some gene mutations and for some genes. And there is some specific guidelines how to dealing with these patients, like in hereditary breast and ovarian cancer. There are 4 genes which are maybe, I would like to stress these mutations or variations in these genes may be acquired and may be germline mutations. Mostly, if we are looking on tissue samples, we can identify the patients which have this microsatellite instability, and most of these patients have no any germline mutations, but they are probably respond well to the immunotherapy, and they have needs some changes in management. There are different cancers which are related to the Lynch syndrome, and as you know, the most common is colorectal cancer, and we are looking also endometrial cancer, and our project including also other Lynch-related cancers. How can we recognize a patient with Lynch syndrome clinically? There are 2 types of guidelines which are looking on family history, on age of patients, and histology. But the second option is looking on the tumor samples. And we decide to looking on tumor samples, and our hospital receives more than 10,000 biopsies and surgical material attributed to the cancer. And of these 10,000 samples, almost 2,000 samples are malignant tumors which are associating with Lynch syndrome. And all these patients going through this microsatellite testing by PCR, and if they have a microsatellite instability in tissue, they are providing the consultation from clinical geneticists and also for surgeons, and then we can provide this service for them. Endometrial cancer is something different. It goes, all the patients go through the PCR and also goes through the DMMR testing by immunohistochemistry, and then they are going further for the genetic counseling if they agree to do this. Immunohistochemistry we are doing in our pathology lab. PCR we are doing with semi-automatic ideal biocartis system, which are looking on 7 biomarkers. NGS we are doing in tissue samples and in constitutional samples by Sure Select Cancer CPG panel, using Illumina Novasec sequencing systems, and ideal I told 7 markers we are looking, and the pathologists are looking the samples of the tumor. We can see here the sample from patient with Lynch syndrome, with some of these proteins are decreased in expressivity is decreased. This is a normal sample. This is NGS data. And what was the result? We are doing this analysis almost 10 months, and this is summarizing for colorectal cancer and other gastrointestinal cancers. And we can see we did 700 tests, and 10% are MSI unstable. This is according to the data of the literature. Nothing new, but it's new because before 3 years, only 16 analyses per year we are doing by DMMR. Now it's every patient who detected cancer related to the Lynch syndrome are going through this testing. And these patients which are positive for MSI high, we are offering the genetic counseling and further surveillance and patient relative testing if there is some germline mutations. This is a summary from patients with endometrial cancer, and there is different situation if the genetic testing by PCR is positive, is always positive, is always indicates mismatch repair deficiency, but it's if it's not if it's normal result, it doesn't mean automatically the patient have now this repair defect in endometrial cancer, and we are going further for testing for validation methods with NGS to detect in tumor tissue and establish values because NGS are looking to 40, 60 microsatellites, this gene panel, and we can decide more precisely about is there some changes or not some changes. And this is a clinical results for clinical germline testing. If we are looking here, some of patients agreed to consultations, and we did germline testing for 44 patients with microsatellite instability in tissue. And now this table summarizes the patients with Lynch syndrome mutations. And you can see the gene, genetic variant, tumor sample, stage at the diagnosis, and the age at the diagnosis. If we are looking on the age, the diagnosis, some of these patients are not always so young, how can we imagine, and sometimes they have some other cancers or sequential cancers, the repeated colon adenocarcinomas in other places. And our clinical geneticists are very fond to these secondary findings, and we are reporting the secondary findings in this germline testing. And if we are looking on these findings, so we can see most of them are, except TP53, most of them are medium penetrance genes which are mutated in these patients. These are germline mutations, and you can see the types of the cancer and the age at the diagnosis. So many genetic consultations are provided and still will be provided next 6 months. And of course, some of patients decline the genetic testing and decline the counseling. And our counseling and this prevention is doing almost always according to NNC guidelines for such. I would like to thank this very large team. I'm a small part of this team, and many thanks to surgeons, Artis Prizan, which is responsible for endometrial cancer, Dr. Anders Trokens, which is leading surgery. Our project lead is Professor Baiba Lāce, which together with Daiga, providing this genetic counseling. We have a team of NGS team, and we have a pathologist team, from which Inga Bogdanova is leading expert, and also this precision oncology department in our hospital. Thank you very much.
Thank you very much. And now we are moving from the oncology into the field of cardiology. And I'm very happy to present Professor Gustavs Latkovskis. He's a clinical and interventional cardiologist at Stradins Clinical University Hospital. And he will be talking about the personalized approach to high cholesterol related disease.
So good morning, everyone. Thank you for your kind introduction. How many of you know your cholesterol levels? So there's a task to do. So, and one might wonder, okay, I just measured the cholesterol, what's so personalized about it? So my task is to convince you that this is really important, and behind just simply elevated cholesterol levels, there can be various scenarios behind it, genetically and otherwise. But first, let's focus what is the terminology. So nowadays, when most of us in our societies, we have the bad cholesterol, LDL cholesterol level, somewhere around 3 to 4 millimoles per liter, we know that actually it's too much for every one of us. And actually most of the animal species have LDL cholesterol level well below 1.8 millimoles per liter, and that's why they usually don't develop in natural habitats atherosclerosis. Also, we know that newborns, when they're born, usually have somewhat in that range cholesterol levels. So by hypercholesterolemia, or severe hypercholesterolemia, we understand when LDL cholesterol level is above 5. And the first thing we should suspect, maybe this individual has so-called heterozygous familial hypercholesterolemia, and I'll explain in next slides what it is. And if it's above 10 millimoles per liter, one might suspect a rare disease, homozygous FH, where 2 alleles are inherited from both parents, and it's truly a rare disease. Heterozygous FH is not a rare disease, so it's rather common, and the prevalence is actually quite similar to just before mentioned Lynch syndrome. So when we look at the whole spectrum of hypercholesterolemia, actually the majority of these cases will not be FH patients. There will be a smaller proportion which is where people meet the clinical criteria of FH. I will not go into the details. There are physical signs, there's a family history, etc. And also only a, not minority, but only a proportion of them will have also genetic mutations that are typical for familial hypercholesterolemia. And the question is, what are the remaining FH cases? And I'll also touch upon the polygenic dyslipidemia. Why it is important to recognize out of all these individuals, those who have FH, especially with positive causal genetic variants, either pathogenic or likely pathogenic according to the definitions, it's important because these individuals have very high cardiovascular risk, and actually they should start the treatment as soon as they become adults, but also in some more severe cases, the treatment should be started also in childhood, starting from age usually 10. So the mechanism behind FH is that there's impaired clearance of LDL particles into the liver, which leads to accumulation and early atherosclerosis. And there are 3 typical candidate genes for that. Most commonly, this is the defect in LDL receptor, which is not able to take up LDL particles in the liver. The second most common is ApoB, which is a ligand placed on the LDL particles that connects to LDL receptor. And then there's PCSK9, which regulates the expression of LDL receptors. In case of gain of function, there's a FH phenotype as well. Just to illustrate how important it is to recognize those individuals who truly have FH, and especially with positive mutations, is this very interesting study by Amit Khera, where they reported that individuals, whatever is the cholesterol level, so the light blue bars are those individuals in the range, in each range where no mutation is found, but with the same exact range of LDL cholesterol. If the mutation is found, then actually this cardiovascular risk is 2 to 3 or even more times higher. And if you compare those who have the highest LDL cholesterol plus genetic mutation compared to those who have the lowest without mutation, there's even 22 times higher risk of cardiovascular disease. And why it is so? Because those individuals who are born with this inherited mutation, they have very high LDL cholesterol levels starting from the first days of their life. And by the age of 30, 35 years, they actually have received such exposure of cholesterol to their blood vessels that normally you would see in an individual at the age of 60, 70, or 80. And that's why these individuals tend to develop very early atherosclerosis, and they are at very high risk, and therefore they should be identified timely. So if I see an individual with LDL cholesterol, let's say 5 millimoles per liter, I should deep dive and understand what are the mechanisms behind it, because somebody who has just because of the lifestyle or polygenic mechanism, well, mostly because of the lifestyle, their cholesterol levels probably during the previous years of the life have been lower compared to somebody who has truly FH. And those who have FH, they can develop very early atherosclerosis, and here are some examples of my patients. whom I've been taking care of. And these are very young individuals, and these are coronary angiograms of their blood vessels. Normally they should look smooth without narrowings, and you can see that that they all have quite severe atherosclerosis, and one of the youngest individuals is at the age of 27, who actually has also just we received that also the LDL receptor genetic variant found. So all these individuals actually should have been diagnosed early, and the best age when we should start screening for FH is at age 5 to 6 at least. It should be preschool age, so that we detect them early. We start prevention, because this is absolutely not curable but very well treatable disease. By starting not very expensive drugs lifelong, you can avoid these atherosclerotic complications, and sometimes and also prevent early death. But it's not so. I mean, there are certain challenges also in interpretation of cholesterol, and one thing is that our cholesterol levels change over our lifetime. And in the childhood, we have it much lower, and usually somewhere around 2.5 millimoles per liter physiologically, maybe even less. But by the age of 18 and more, then it starts growing up and increasing, and therefore, after the age of 20, 30, it gets more and more difficult to dissect these, to distinguish these individuals just by looking at LDL cholesterol levels. And therefore, the best time when we should screen for FH is age, well, as early as possible, typically before the school age, somewhere around 5, 6, 7. And this is also actually we are launching with the GPs a pilot in Latvia, how we will screen the FH in our population, but so at this very early age, if a child has LDL above 3.5, which would be normal for an adult person, not normal but quite usual, that would be a very strong suggestion that maybe this individual has familial hypercholesterolemia and should be carefully investigated further, both genetically, etc. However, despite the presence of all the clinical criteria to diagnose FH, in many populations, not all of these individuals actually do have genetic background explained. And we still see many families where there's this trait of very high cholesterol levels and early atherosclerosis in several generations. Yet we are unable to find the explanation, and no good explanation of this so-called monogenic disease. So, but if we find this, it is very important that first to understand that the cardiovascular risk is very high. These should be treated aggressively very early. Second point is, remember, this is family disease. We should perform the cascade screening for all the first-degree blood relatives, siblings, children, sometimes even parents. And actually, this is the idea also of the reverse screening in case of, if we identify FH in the children, both parents should be screened as well. But then the next question is, what are the other explanations of high cholesterol levels? And one of them is so-called polygenic hypercholesterolemia. In contrast to monogenic hypercholesterolemia, where there's only one single genetic variant which has a huge impact on lipid metabolism, in case of polygenic hypercholesterolemia, there are numerous genes and numerous genetic variations who can actually slightly increase or decrease our cholesterol levels, but each separately has a very minor effect. But if you have like 200 such which happen to have increasing effect, all this works as a choir and leads to quite high cholesterol levels. One of the earliest studies which demonstrated that this polygenic score, and there are various polygenic scores, and this was one of the, not only first, but also were the fewest number of these genetic variants were included in the score. It demonstrated the top decile versus the lowest 10% of individuals, according to this polygenic risk score, can have as high as 1.5 millimoles per liter difference, or with some other scores, it's even higher. Interestingly, also this score correlates with increased risk of cardiovascular disease, and this has been replicated with various scores. Although this risk is not as high as for the monogenic cases, even after adjustment for LDL cholesterol levels, but still it is more than for those who have just simply elevated LDL cholesterol levels and without monogenic mutation or other explanations for that. And it can be, if it's more than 99% of the polygenic risk score, it is not exactly the same, but it starts becoming a little bit more comparable to the risk that can be associated with monogenic cases. In Latvia, 10 years ago, we established Latvian Registry of FH for adult patients. Currently, we have probably 1,700 individuals in our database, somewhere around 600 or more individuals with diagnosed FH, and we strongly collaborate with Biomedical Research and Studies Center with Professor Jānis Kloviņš group, and we try to involve all these individuals also in the Latvian genome database, and from that we generate quite a few also research. But the thing is that in Latvia we estimate that there should be somewhere around 7,000 to 8,000 individuals with this disease, so we are very far from identifying all of them, and it seems that we have currently covered only 10% of the estimated patient population. So one of our latest publications was focused on to understand this genetic background of our patients who phenotypically have this FH and with a clinical diagnosis, and only in 21.5% of cases we were able to identify a pathogenic or likely pathogenic, so this monogenic cause, which confirms familial hypercholesterolemia. Then we went further. We also, in this whole genome sequencing, we looked at some other so-called phenocopies, and there were 7 cases which could explain also, well, 2 of them surely are some rare disease I will mention later. But nevertheless, this is a quite small percentage. And then we looked at this polygenic risk score with 223 genes in the score, genetic variants in the score, and it was another 20%. So in fact, out of all our studied patients, only in 43% of cases, we were able to explain this very high cholesterol genetically. And of course, this is, on one hand, it's disappointing. On the other hand, it is fascinating that there's a perspective that probably there are many other mechanisms which are still yet to be identified. But in this case, as opposed to monogenic familial hypercholesterolemia, the genetic cascade screening is not indicated, but in these individuals we know that the cardiovascular risk is higher if we hadn't found, if the polygenic risk score would have been lower. So among these all patients, we identified 2 young female patients who actually turned out to have a rare disease, which is called lysosomal acid lipase deficiency, or LALD, which is a defect where cholesterol esters and also triglycerides are built up in liver. This disease may have 2 types of presentation. One is early in children with quite severe phenotype, which can be life-threatening, but in some adults, these may also manifest as a milder form. As a matter of fact, we had previously screened quite many patients with specifically for this disease, and always these tests came back negative. So it was a sort of a surprise because we were not suspecting this condition in these particular cases, and this was confirmed by Glasgow laboratory where they analyzed the LAL activity. Then another thing that we should keep in mind that maybe behind the LDL cholesterol level, this is another particle which also contains cholesterol. So this is so-called lipoprotein little a, which is a bit strange molecule in our bodies, the particle, because it is a typical LDL particle, but it has also this apo little a. This is a sort of a chain that is that actually makes it more atherogenic, and also leads also to aortic stenosis, not only atherosclerotic events. It's not clear what is the function. Maybe it improves healing. What makes it even more strange that human beings are the only ones who have these kinds of particles, but there's one more species, and these are hedgehogs, and these are not really, very close ancient relatives of us, so it's a little bit strange how this comes to it. But anyway, so the higher is LP little a, the larger part of the LDL cholesterol could be attributed to this LPA cholesterol. And also, if we identify a patient with a very high LP little a, it may partially explain high cholesterol levels, but also it adds very significantly to the cardiovascular risk, and sometimes, in some cases, it can even double or triple the cardiovascular risk, so it's important to take into account. And the last point that I wanted to just illustrate how complicated it can be, in some individuals, there's a paradoxical increase of cholesterol if they start the keto diet, they restrict the carbohydrates in their diet, and especially if they have a lean body mass and low triglycerides. I'll not go into all the details, but the thing is that sometimes these LDL cholesterol levels can go up to 2 to 3 times from almost normal to, let's say, over 7 or 8 or 10 millimoles per liter. So to conclude, what hides behind the severe hypercholesterolemia? Of course, we first should suspect FH, and these are the cases where the risk is the highest. Then these can be phenocopies, which can be difficult to diagnose unless we use this genetic testing. Polygenic hypercholesterolemia, another one which can explain many cases and is associated with increased cardiovascular risk. High LP little a, lean mass, hyperresponders, but finally, yes, it can be just our lifestyle. So this is our team who has contributed to our work that we are doing, and thank you for your attention.
Thank you very much. And the last but not least speaker is also related with the field of the precision medicine, but here we're going to see a little bit different look at the precision medicine. And I'm happy to invite Laura Valtere. She's a postdoctoral fellow at the Center for Advanced Studies in Bioscience Innovation Law. And her speech will going to be about the precision medicine innovation in sensitives and access.
Good morning, ladies and gentlemen. It's a great pleasure to be here today at a conference dedicated to precision medicine. As the only legal researcher speaking at this event, I offer a complementary perspective, one that focuses not on molecules and trials, but on the legal and regulatory frameworks that enable scientific breakthroughs to reach patients. And precision medicine thrives on innovation, yet the innovation is dependent on the right incentives and the regulatory structures. And that's the focus of my today's presentation. What do we want to incentivize in regard to precision medicine? It's about innovation, it's about access, and what is an incentive? It's a benefit, signal, or consequence that is designed to encourage a specific behavior or outcome. When we speak about innovation incentives, besides tax credits and direct financial awards, we speak about patents that afford 20-year protection, exclusivity, for specific patentable subject matters. Ultimately, you obtain formal rights but the patentable subject matter has to go through examination, registration, and it involves annual fees to maintain the patent in force. There are also exceptions to patentability, so certain subject matters are excluded, and there are also exceptions to patent infringement, meaning that certain acts are permitted to be undertaken without the permission and without constituting an infringement, for example, research exemption or the so-called Bolar exemption. And then we have regulatory exclusivities. Differently from patents, patents are technology neutral, so you can obtain it for any kind of innovation. Regulatory exclusivities are specifically dedicated for medicinal products, and regulatory exclusivity grants time-limited protection that is tied to marketing authorization, and it basically prevents generic competitors from relying on an originator's clinical and preclinical data, and hence from launching generic products. We have 8 + 2 years protection that is available for any new medicinal product that contains active ingredient not registered before. In regard to precision medicine, we have also orphan drug protection, which may overlap with the precision medicine, and it awards very strong protection of 12 years. This means that regulatory exclusivities provide targeted incentives. Besides orphan drug protection, we also have pediatric exclusivity. And the benefit is that these rights are, so to say, almost automatic because it doesn't require any examination, registration, and enforcement is also in the control of the regulator. So no competing generic product is being authorized during the protection term. I have invested quite a lot of time to investigate whether personalized medicine or precision medicine can benefit from these. My monography focuses on personalized medicine diagnostics and subpopulation drugs, while the latest article specifically on personalized gene therapies. And as you may feel, there is no such a product as personalized medicine. It's a concept or approach. And that's why the first task was to distinguish what could be patentable subject matter. And while substances and diagnostic methods conducted ex vivo can be patented, for example, methods of treatments such as gene therapies or cell therapies cannot. What are then these benefits of patent protection? First and foremost, that's also the rationale of patent system, is that it's investment protection function. Already mid-20th century, Matchlab said that the patents do not so much incentivize innovation as they incentivize investment in innovation. Other benefit is ownership allocation. So it's a coordination role by allocating legally enforceable ownership over an innovation, which in turn makes licensing, for example, feasible, but also priceable and enforceable. It also gives signals to venture capital or in public research to funding opportunities. Patents can also be used as bargaining chips for cross-licensing, and they also signal inventiveness. Besides that, it has disclosure function, so patent applications are being disclosed, so no duplication of efforts are there. And also innovation function, because disclosure allows us to build on the existing knowledge. And after 20 years, patent elapses and everyone can work the invention. And regulatory exclusivities, that's a bit different story. It's a balancing of interests. There was a long time period issue about generic market entry, and with regulatory exclusivity, first it's actually enabled the generics can market products without conducting full clinical and preclinical trials, instead relying on the originator's data. But the originator obtains certain period of time when generics are not permitted to be authorized, hence limiting the imitation competition. And regulatory exclusivities also provide investment incentive beyond patents and prevents free riding, but for the most, they offer also targeted incentives, for example, for orphan drugs or pediatric drugs. When we speak about innovation versus access, it describes the core economic tension in pharmaceuticals. So exclusivities and pricing power can motivate R&D that fields further therapies, it's the dynamic efficiency, but they also raise price today and restrict consumption below the competitive, socially efficient level. So it's the static inefficiency. And the policy problem is to calibrate protection, pricing, and complementary tools. So near-term access losses are justified by long-term innovation gains that improve welfare over time. But in this framework of precision medicine, we have fundamental questions. Are exclusivity rights useful for personalized treatments? We have limited markets in sense the patient populations are limited, so that even with exclusivity right, return on investment is hardly possible, so that the field is not that interesting for the industry. And imitation is by nature limited. Most of precision medicine products are complex biologics, which imitation is per se complicated. So, the effect of the exclusivity depends on various factors and also product types. Especially my analysis has shown that it's in regard to gene and cell therapies, and it's for the reason that not the exclusivity right is incentive, but the market, unfortunately. And if the market is small, then also with exclusivity right, it will not get bigger. Then we come to the fundamental question, what kind of solutions can we find, especially considering that gene therapies, the authorized amount of gene therapies in Europe is lagging behind other regions. So how are we going further? We see that public research in universities and public research institutes play probably the most important role in this sector. And there are good examples. For example, CREATIC project that is coordinated by the Masaryk University in Brno with other partners in Germany, Fraunhofer and Leipzig University, and my University of Copenhagen. And their goal is to build scientific, clinical, and manufacturing capabilities around advanced therapy medicinal products. That's the regulatory category of gene and cell therapies. The goal is to create an ecosystem that connects academia, industry, healthcare providers, and regulators to accelerate clinical trials and real-world deployment. What's going there is that first scientific capacities, but also the correct legal frameworks are being investigated for enabling ATMPs being produced in Czech Republic and in broader cooperations. So in regard to precision medicine, we might come to two keywords. One is coordination with clear goals determination. What do we want and where do we want and how do we reach? And cooperation. National, but for the most regional, European Union level, but also public and private sectors as well as regulators. And we have hospital exemption. In Europe, it applies to advanced therapy medicinal products that are prepared on a non-routine basis, used in a hospital under the exclusive professional responsibility of medical practitioner, pursuant to an individual medicinal prescription and for limited amount of patients. It's not a mass production, and it's rather an exception to the general authorization. It's not an alternative route, though. What does it mean? So in Europe, no product can be deployed without the marketing authorization. But standard marketing authorization grant costs a lot of monies, and it's also a time-consuming process. Considering that precision medicine will be deployed for a limited amount of patients, industry will inevitably has little interest in especially very rare precision medicine. And hospital exemption is one way how hospitals can deploy precision medicine without going the full marketing authorization route, which is not only economically but often also scientifically not feasible. Currently, there is probably the biggest legislative action in a generation in the European Union. So the general pharmaceutical legislation has been reviewed, and also hospital exemption is a part of a broader debate. And if we check the available information, well, some member states have explicit regulation on how to deploy or how to use the hospital exemption to enable precision medicine availability. Nationally, some states, included Latvia, has no regulation on this and no actually data on what kind of therapies have been applied, at least according to the European Union research. What is this proposal about? They propose to collect and report data and to publish by the agency, European Medicines Agency. Before this proposal came out, I started a project to rethink hospital exemption as such. And our research showed that the hospital exemption is actually the backbone of current gene therapy administration in the European Union, as it's a key gateway to ensure the supply of such therapies for individual patients. If we see the statistics, there are more gene therapies authorized via hospital exemption than via centralized marketing authorization by industry. And we invite to rethink the objective of hospital exemption and its potential. First as a stepping stone from a non-routine preparation to later scaling up, and secondly as a bridging mechanism between research and industry. And the proposal is to introduce reporting duties. European Union has intention to introduce basic reporting. Industry would also like to see extended. We think that extended reporting should not be mandatory, but for those hospitals who does this, there should be a compensation mechanism. First, to act as an incentive for collecting and reporting such data, and secondly, to not to put too big burden on hospitals, because it's an extra administrative step and it costs extra finances. And in this way, this hospital exemption would also then fulfill data function. And the collected information that is registered and administered at the EU level is definitely welcomed, because it would support the development of new ATMPs authorized centrally, but also provide insights into hospitals with specific expertise. And the goal of extended reporting would be to incentivize then undertaking clinical trials and facilitate marketing authorization. And it's more feasible once the commercial and therapeutic success assessment is enabled. We were also thinking what should be the source of this remuneration, right? And public budget would be the most appropriate, was our conclusion, not to make direct burden on patient or national health insurances. Then I raised before this conference other access questions, especially in regard to national context, Latvia, but not only. We have generally in Europe problem with innovative medicines availability across member states. That's what we see, that larger and wealthier markets have broad spectrum of medicines available, while smaller markets not. There are known reasons for that. And Latvia is actually lagging very behind all the other states. One of the least number of available innovative medicines we have here, and one of the longest timelines to authorization and launch. After meetings with patient organizations in Latvia, I had an impression about that there is low understanding on innovative medicines relevance between the administrators. And issues may also lie with low regulatory coordination. What are the priorities in research? Do we have empiric patient data? What is needed? And in regard to access, such as procurement and prices, which is also a topical issue here, maybe lessened, or definitely lessons should be learned from regional cooperations, such as the Benelux initiative. because if the market is small and the patient amount is not large and the state is generally smaller, this bargaining power in negotiations with the pharma industry is much more difficult. But if you connect together with other member states, as in this Benelux initiative, you have more success with getting faster and also for better price medicinal products. And another issue is national innovation habitat, and Latvia should rethink seriously technology transfer. What is with university and public research institute spin-offs and innovation licensing. And we have neighbors, we don't have to look that far, who are very successful in this field, and there would be very welcome making it possible also to thrive in technology transfer sector, especially considering that precision medicine will most likely have its epicentrum in public research institutions. And then we have very old question about precision medicine prices, but this we will leave open for the next conference, I guess. Thank you very much.
Our apologies. Thank you very much. So now I would love to invite all the speakers here in front for the panel discussion that we have approximately 20 minutes time before the lunch. So to generate the activity. No, you can go there. I'm probably gonna take a chair and then join you. Yeah, I can take a chair and join you. So do we have any questions from the public? If, while the public is thinking about the questions, I have some questions for each speaker, starting with our Estonian colleague Kristina Ojamaa. I wanted to ask you, maybe I missed it in your speech, like, so who is financing this Drup-like clinical trial in Estonia?
It's working, no? Yeah. It's working, yeah? Okay, it's complex, but we have the trial as partners, which are pharmaceutical companies. Now we have a first partner who is Novartis. It's going to be Novartis, I should say now. And we got the startup finances from the from Tartu University Hospital. And if we talk about the drugs and the treatment itself, so it is almost the same talk that Nancy actually presented. After the 4 months, 16 weeks of treatment on the stage 3, there is more than 54 patients. So if the drug is beneficial for a patient, so the healthcare system in Estonia, it's a health fund, national health fund should take care of the reimbursement of the drug. So we have had these negotiations, all 3 of us, and I'm in the company, and the health fund, and us as the people who actually conducted the study. So we have an agreement.
Thank you. And one more question: is it one center trial, or do you have multiple centers participating in this trial?
It's a nationwide. So we have 3 cancer centers, so all are involved.
Thank you. And how, well, that's a little bit like more scientific question, is like how many patients from the endometrial and ovarian cancer harbor this PIK3 mutation? Because you were saying like you will going to be including the patients with this mutation. So what will happen with the patients who don't have that mutation?
Actually, it's straight to the topic, yes, the question. So a lot of, actually, and you know, it's this type of cancer that they actually chose there. These are the type of cancers that have no good options for standard treatment, and hormonal treatment is one of that they can benefit. But if they have this BA3K mutation, so the hormone treatment doesn't work. So we have some data about alpelisib working in this area, and I think it's a very good start.
Thank you. Anybody else has maybe questions to our colleague? No? Then I will, oh, yeah. Sorry.
Thank you so much. I'm Vladislava Marana from Research-Based Pharmaceuticals Manufacturers Association here in Latvia. And I have questions about last presentations that I found very interesting, because of course regulatory data protection and environment that we have in the EU now is a very big question, especially also when we see what happens in US and tariffs that also affect us. You looked at incentives for precision medicine, but hearing your presentation, I was wondering, did you look at how general incentives and the environment we have in the EU, what spillover effects it would have then for development of precision medicines? Because, of course, from the industry side, precision medicine doesn't happen in silo, right? You have bigger portfolio and many other things going on. And then second question, I will have two, about hospital exemption. I know that in Latvia now the regulation is on the way. Apparently nothing is happening yet, but it's coming. What is your opinion on Latvia? What opportunities we have in this field? And I mean, countries approach it from in different ways, right? So what would you say about Latvia then? Thank you.
Thank you very much for your questions. In regard to Latvia, it's very difficult to say because we did not have any regulation before, but that doesn't mean that the hospital exemption didn't exist here. Unofficial information, there have been hospital exemptions. So I don't have data what I can, look through and compare. But if I view data from Europe, and for example, Germany and Poland and other states, they have very clear route of how a hospital exemption can be deployed. And it shows that these states have also more often employed it. Probably in this occasion, regulation does not harm. We are always afraid that regulation will block any kind of, freedom so that the action will not take place, but the data in regard to hospital exemption shows the opposite. I would suggest Latvia to wait a bit until the European Union legislative package has been enacted, because there will be definitely changes in regard to hospital exemption. It will not look as it looks now. But yeah, for sure, I'm quite certain that smaller states that usually are not the target of the industry in sense of delivery of products will probably be interested in deploying more hospital exemption than larger and wealthier markets. I hope I answered your question. And about the first question, for sure, patents and regulatory exclusivities, these are not the only one incentives. Also, venture capital availability or technology transfer, I already mentioned. There are various factors. Also, public funding, such as milestone payments, or how easy or fast is actually the deployment of medicinal products onto a certain market. These are all questions that come into this incentive package, which pharma industry is very important for. That would be my answer. Thank you.
Thank you very much.
I also have a question to you. From purely clinical point of view, we face the situation that in Latvia, and similarly in other small countries, we just do not have certain drugs, innovative drugs available. And usually the pharmaceutical companies just state, well, you're too small to go there. So we have this new and this and that very nice product in hematology or elsewhere in other field, but it's not going to be in Latvia. And similarly, we have seen that for my patients who have very rare lipid disorders, it's very difficult to get them. So, and it's not even about reimbursement, but just going into our market. So I was just wondering if there's any chance that at the level of European Union legislation, this could be somehow solved.
This is quite problematic because it's a national competency, but we already see that in the sector of antimicrobials, there is a proposal to introduce joint procurement. So member states come together, and then you have bigger market together, and you are more interesting for pharma industry, and they can also estimate whether they can generate return on investment or not. Unfortunately, pharma industry, they are not philanthropic, they are profit driven, and if they don't see that they can obtain return on investment, they don't go to these markets. But in this moment, I would highly suggest for smaller markets to generate self-sufficiency, in the sense that you have great scientists here. I don't know your capacity, but I guess it's possible to probably to manufacture some of these products by your own, and hospital exemption is the way how you can legally also deploy them. I have an information about smaller markets, they do this. Even though if there is a gene therapy, for example, centrally authorized, and this gene therapy is not available in the certain state, because it's not interesting most likely for the industry, they can manufacture themselves. You still have to comply with quality standards though, but it's a way how to obtain the output for you, what you want.
The patent would be the obstacle, I think.
Excuse me?
But there's a patent on the drug, so it's not always an option, I guess.
That's another question. That's what I spoke. It's about the regulatory side. True, there is a patent, yeah, but it's one option is to get a license, which
costs.
Which may cost, but it's about negotiation. If you are a public hospital, you have good chances to also get very reasonable price. The other is to not license and hope that the company will not, because it's not, public information. The treatment is usually patient secrecy information. Yeah.
So it seems that there are still solutions to look for and try to find. I have the question to Professor Latkovskis and Dr. Dzalbs about the screening panels. Like you both were talking about the different genomic alterations related with the diseases. Do you have already the panels or in each of your fields? Like you are assessing these DNA mismatch repair genes, you were talking about 7 or what?
Of course, we have commercially available panels for germline testing, and for tissue testing we use comprehensive cancer panel with more than 600 genes including in this panel. Yes, it's NGS based, and PCR is 7 markers by PCR. Yeah, it's all commercial available, and even CE-IVD marked. It's clinical practice. Yes.
Well, it's quite opposite in case of familial hypercholesterolemia. We know there are these candidate genes, so LDL receptor, ApoB, very rarely PCSK9, which is maybe in 1 out of more than 100 cases found. We've never found one. But the thing is that there's a huge variation of those genetic variants that can cause the disease. So there's, for instance, there used to be one panel with 8 mutations, and when this was tested in Latvia, none of our patients had it. So actually, it's a genome sequencing, and you just look at those candidate variants, you look in the ClinVar system whether it is there, and then you look for other potential candidates, and then they should be evaluated according to modified criteria, ICMG, specifically for LDL receptor, and sometimes you just find some that are never previously described, and probably also those who are gene negative, mutation negative cases. Many of them have these VUSs, variants of unknown significance, that probably are could be the reason why they have this high cholesterol, but you have yet to confirm it with various methods.
And if I may continue with the question about this high cholesterol disease that I can't pronounce correctly. lipo A, LDA. Is it tested? Do we have available tests for determining the levels or presence of LDA?
So yes, lipoprotein little a, as we call it, with a small a in the brackets. Yes, this test has been available for many years. It is available also in Latvia, in our countries. Just point of caution that there are two types of tests, well, two types of units that can be used, milligrams per deciliter or nanomoles per liter, and there are different thresholds to understand whether it is elevated and how, and you cannot convert from one to another because this is a special. These particles have many isoforms, and therefore nanomoles per liter do not correspond exactly to milligrams per deciliter. Anyway, this is available. It is strongly genetically determined, so 90% of the level can be predicted genetically, and therefore currently it is being said that this is once per lifetime analysis. There are cases where we repeat the testing, but just do it at least once. And in Latvia, it costs like €7 or even less. So it should be done.
So I understand, like, if you get this, you have this, you either have or you do not have this.
You can measure quantitatively the level of it. And if it is above 50 milligrams per deciliter or 105 nanomoles per liter, it is regarded as elevated risk. But then if it is twice higher or 3 times higher, then it's really hugely elevated risk in addition to what you have. And actually in Latvian, in this project that we have for cardiovascular health in Latvia, which has currently just passed some first stages in the bureaucracy, it has been included that this LP(a) testing should be reimbursed starting from age 40 in Latvia.
Age 40?
Age 40.
40.
40, yeah.
Okay. Any questions from the audience? I do not see. Do you maybe have some final remarks after this session, like wishes or looking forward?
Yes, I think I definitely have. As I mentioned, my keywords were cooperation, data collection, and actually already former speakers mentioned these, and this was very nice reflection and in my presentation as well, that brings together medicinal practitioner view with the regulatory frameworks view. And this is what I wish: cooperate, collect data, and benefit from cooperation and data sharing and collection.
Okay, so maybe in conclusion, I should say that this type of trials or molecular oncology developments are possible only if research and science meets clinical practice. And in Estonia, it was quite a small one. Only we didn't have much funds. So we still don't have much funds for research, and also we don't have much funds in clinical practice as well. But we find a way, and we have a wish. And the most important thing is, if somebody also talked, maybe you again, about this, that if we want to make an impact, we have to involve all parties, academia, we have private practice, everything, education, we have to involve in, but the most important, patients and people themselves. If we don't talk about the things the way that people understand, we can't make an impact at all. Yeah. Sorry.
Thank you very much for attention, and also thank you very much our sponsors, National Health Service. I hope this is our project just for 1 year, 3 months. I will hope it's somehow continues this service for the patients, and the patients get the same service as in another country, like in Estonia. It's much more reimbursement in therapies and also in genetic testing. Thank you very much.
Yeah, I think we all understand that precision medicine is not something very fancy. It is already in our practice, and it is absolute necessity because, of course, our financial situations in many countries and healthcare budget cannot afford to treat everyone with all these new drugs that are coming, and we need to stratify how best to spend our money. And for that, of course, we need local research, we need local databases, and I hope our governments will encourage that.
Well, I thank all our speakers. Thank you for your concluding remarks. We are exactly on time. It's 12 o'clock. And thank you, audience, for your patience and interest in this session. So I wish you good appetite, and I will see you in an hour back here. Thank you.